their sleeves on the ground. Listening to these speakers is essential. Their experiences can guide us in refining global health strategies. So 6 oral presentations will report on experiences in Kenya, Moldova, Pakistan, Ukraine, and Italy. And speaking of Italy, that's where our next moderator is from. This session, just like yesterday, will be divided in 2 parts. We will have 2 moderators. One will be moderating each part. So our first moderator is a research and methodology advisor at the Red Cross in Geneva. He has over 20 years of experience in humanitarian settings in Africa and the Middle East with the International Committee of the Red Cross. His experience includes vaccination and outbreak investigation and its response. So we're talking about Mr. Rodolfo Rossi. Please welcome him on stage.
Thank you. Good afternoon, everyone. Displaced population, being this in Pakistan, Middle East, Europe, experience formidable challenges ranging from limited access to care, limited legal support, and inhumane survival coping mechanism. So we will hear about these challenges in the next representation on research that has been conducted on refugees and displaced population by 3 distinguished panelists that I'm going to introduce. We will let them have a few minutes for question and answers before passing 3 other presentations. So we kindly ask the presenters to stay on the time that was given to them and for the question and answer to be very short because I think the day has been long and we are all tired and move on. So our first speaker is Dr. Saeed Ahmad, a public health professional from Pakistan. He collaborated with the CDC Atlanta, with the Health Security Agency of the United Kingdom and the WHO. Dr. Ahmad's expertise revolves around health system segmenting, health equity, global health security, and international health regulations. He will talk to us about a research on the health outcome of Afghan refugees in Pakistan. Dr. Saeed Ahmad, please join us on the stage.
Thank you very much, and hello to all of you. I'm glad to be here and on this August forum. Without much further ado, I'm going to talk about assessing the health disparities and access of Afghan refugee health in Pakistan through data-driven analysis. Pakistan remains one of the world's largest refugee hosting country in the world with 1.3 million registered refugees, 99% of which are Afghans. Health is a crucial aspect of refugee lives, as we all know, and the management of health data for Afghan refugees in Pakistan is conducted through a separate refugee health information system, which is very much existent in Pakistan. This system operates across 54 Afghan refugees' villages and is overseen by the Department of Health. The Refugee Health Information System is not integrated, unfortunately, with the National Health Information System in Pakistan. So that is the main cause of lack of data reporting and the health disparities which are arising out of this issue. So this disconnect highlights the urgent need of reliable health data, because until and unless we have reliable health data, we cannot actually take action in the light of that. So reliable data is essential for evidence-based decision-making and ensuring health equity among Afghan population. This study, which I'm going to talk about, it seeks to evaluate the disparities in health status and healthcare access between Afghan refugees and permanent residents in Pakistan. The assessment employs the global reference list of 2018 of 100 core health indicators by WHO as a framework. This has been used as a benchmark. And the primary objective of this study is to utilize the population-based cross-sectional analysis to compare health data obtained from Afghan refugees and the resident of Pakistani population. And it is imperative to mention over here, ladies and gentlemen, that influx of Afghan refugees in Pakistan occurred in 1979, soon after Russian invasion. So after that, Pakistan was flooded with Afghan refugees, and since then, now it is the second and third generation of Afghan refugees who are living in Pakistan. And not only that has led to various socio-economic challenges, but health is, of course, one of them. So health has been an issue as far as the influx of Afghan population in Pakistan has been concerned. The methodology which has been used for this study is that a population-based cross-sectional study was conducted using 2021 data. And of course, we had a lot of challenges since COVID hit in. So, but like 2021 is a reliable data which is available to us, and that has been utilized in this study. And the study included 960 registered Afghan refugees sourced from the Commissionerate for Afghan Refugees, which is a government authority who is dealing with Afghan refugees in Pakistan. The resident Pakistani population sample comprised 20,000 plus individuals obtained from Pakistan Bureau of Statistics. So this is actually the native population which is already living in those areas. So essential health service coverage indicator focused on malaria and fundamental healthcare services aligned with global reference list, which I'd already talked about. And it is also important to mention over here that global reference list talked about 100 indicators, while as far as the national priority list of Pakistan is concerned, we have 33 priority diseases which are on the national list, and it mainly contains infectious diseases, including TB, AIDS, and malaria. So these indicators served as outcome measures, and the disparities in health and healthcare access were quantified using cross-tabulation and crude odds ratio. The analysis was stratified by age and sex to further examine the disparities. Results were quite intriguing and interesting for me as well. The substantial variation exists in health and access to health care between Afghan refugees and resident population in Pakistan. So simple to say, on one side, Afghan refugees are living in the same town, while in the same town, the native residents are living. So there is a lot of disparity in healthcare access between the two, which is of course concerning as well as a call for action. So crude odds ratio revealed marked disparities in service coverage indicators related to malaria and essential health services. Why malaria has been specifically mentioned here, that it is one of the neglected tropical diseases, and it is very common, especially in those areas of Pakistan which are bordering Afghanistan, and in those areas, most of Afghan refugees are settled over there. And age-stratified and sex-stratified odds ratio showed varying degrees of inequalities as well. So, I mean, inequalities, simple to say that, were actually demonstrated and documented by the statistical analysis as well. So these variations indicate that there's a distinctive disparities across different demographic segments within the refugees and the resident population. Taking this further, the identified disparities highlight the urgent need to address healthcare discrepancies experienced by Afghan refugees in Pakistan, and this is not now, this has been happening since last 3 decades. And the analysis revealed the specific area of concern, including significant inadequacies in healthcare access for malaria and essential health services among the Afghan refugees. The findings underscore the imperative for evidence-based policy intervention, which unfortunately we do not have at the moment so far. Means we have a national action plan for various diseases and to combat many other problems, but those national action plans and strategic frameworks do not account for this very important issue of Afghan refugee health disparities in Pakistan. So interventions should aim to mitigate the health disparities and promote the equitable healthcare access for Afghan refugee population in Pakistan. And this health equity we have been talking about this under universal health coverage. We have been talking it under sustainable development goal. So it is one of the cornerstone of health system all across the world. But this is not the case here when it comes to Afghan refugees health population in Pakistan. To conclude that, this is a call to action. This health disparity, which I'm talking about, which has been demonstrated and documented by my research, this is a call to action for everyone, not only for the policymaker, for the stakeholders sitting on the government side, but also all the partners who are working for Afghan refugee health in Pakistan, not only at the local, but also at the international level. So the urgency of addressing the health disparities and inequities faced by Afghan refugees in Pakistan cannot be overstated. The harsh reality reveals the marked differences in health status and access to essential healthcare services between Afghan refugees and the resident population. So there is an urgent need, as this data reflects, to bridge these gaps in healthcare access and address the health disparities among Afghan refugees. Evidence-based decision-making is essential to facilitate the equitable health outcomes and improve the healthcare access for Afghan refugees in Pakistan. To add insult to this injury, the recent most decision by government of Pakistan to dislocate and dispel and extradite registered Afghan population in Pakistan in the wake of recent security-related challenges and the incidences which occurred in Pakistan, this has actually rang an alarm bell for many, not only in Pakistan but around the world. And among all the strata, the most devastating and the most vulnerable group because of that decision is women and girls and children who are living there. And as I mentioned that this is an irony of fate that this is almost a third generation of Afghan refugees who are now grown up in Pakistan. And now they have, just because of one stroke of pen, they now have to leave that area and they have to be repatriated to Pakistan. And many of them have already departed, some have not. And so this is a wholesome, gruesome situation, I must say, that is occurring and that is arising because of this issue. And we have talking about this let me take this opportunity of this forum, and this is my last few minutes actually, that we have been talking that the migration is not only a problem of health. This is a problem of all the sectors, including policymakers who are actually at the helm of affairs. So lastly, I would like to say that Afghan refugee in Pakistan is also not a health issue. This should be viewed in the larger context, and all the stakeholders must sit together and actually try to resolve this problem on the priority basis in consultation with government of Pakistan, of course. And because the purpose is to bring the health disparities, which already occurred at an alarming scale, and to prevent this to replicate and happen in future because of this recent decision of expelling the Afghan residents who are living in Pakistan. With this message, I thank you very much, and this is the end of my presentation.
Thank you. Thank you very much, Ahmad Said, for the evidence you brought us today. Our second speaker is Diana Berari, who is a psychotherapist and community coordinator in the Health Life Project, reducing the burden of non-communicable disease in the Republic of Moldova. She has 20 years experience in the non-governmental organization sector with a special focus on health promotion and behavior change. Diana will talk to us about a project for Ukrainian refugees in Moldova. So we are very curious to hear about your project. Thank you.
Okay. Good afternoon, everyone. I am pleased to present our project's response to the health and social needs of Ukrainian refugees in Moldova. Healthy Life project began in Moldova in 2018, implemented by Swiss Tropical and the Public Health Institute on behalf of the Swiss Development and Cooperation Agency. Our project focuses on the non-communicable disease and the lifestyle-related risk factors. We collaborate with local authorities, primary health and social care institutions, civil society organizations, and communities. Moldova is a small country located between Romania and Ukraine, with around 2.5 million people. We gained independence from the Soviet Union in 1991, followed by a civil war in 1992. Since 2019, Moldova has classified as upper middle income country according to the World Bank. However, many people still live in poverty, especially the elderly in rural areas. In Moldova, there is a cycle of poor health, low socioeconomic status, and NCD risk factors. Rural population depends heavily on agriculture, and many young people leave the country for the better opportunities. The Russian invasion of Ukraine on February 24th, 2022, greatly affected Moldova. Energy price and inflation skyrocketed, and many refugees entered in our country. According to the recent figures, there have been over 1 million border crossings from Ukraine, and more than 120,000 refugees from Ukraine are currently recorded in Moldova. Our project responded to the influx of refugees by working on different levels. At national levels, our project works with the Ministry of Health and Ministry of Labor and Social Protection. At district level, with local public authorities. The Healthy Life project promotes multidisciplinary teams through joint capacity building exercises, health in all policies, and collaboration with local civil society organizations. We train our community teams through sectorial and multi-sectoral sessions to strengthen their practical abilities. Target audience were staff from primary health care, hospitals, pre-hospitals, emerging care, public health, local public authority run and community, national health insurance company, and of the joint domains, police, education, and mass media. To support primary health care practitioners to responding to increased community needs, project distributed 835 medical kits. Also, project developed a guide from community social workers to better address the specific health and social needs of refugees. We involve refugees in health promotion activities through various inclusive and engaging methods. We're providing small grant to local civil society organizations, holding education seminars on questions related to health. And in each community project, we organize fun activities together with local community groups like dance competition and cooking classes, which included Ukrainian dance and Ukrainian recipes. Also, we conducted chronic disease self-management program in over 6 weeks, focusing on managing health condition, depression, stress, anxiety, pain, and other symptoms. This program was particularly interesting for refugees because it allowed them to share their emotion and experience in a supportive environment. We are facing various operational challenges, including customs control and other administrative challenges. Coordination with civil society organization and closure of accommodation centers. Refugees are experiencing the high level of stress, which also affects the well-being on health and social workers, community, and community facilitators. In this context, the continuous psychological support is essential for everyone involved. Another issue is legal support. In cases of domestic violence, children and adolescents without passports, and the management of cases of children at risk, such as abusive parents. In conclusion, our project strives to support the health and social needs of vulnerable population, including Ukrainian refugees and in Moldova through integrated care, community involvement, and capacity building. The Healthy Life project was able to build on already existing intersectoral collaboration and capacity building activities, which was crucial for addressing the needs of refugees population. Community support and adaptation of primary care level interventions to the needs of the refugee population are necessary and should follow an inclusive approach. And integrated community-based approaches like the chronic disease self-management program can be used as an effective option in supporting refugees' health and host communities' health. Thank you very much for your attention.
Thank you for sharing with us this very interesting project, Jan. Thank you. Since the time of Reproductive Health Matters, when she was editor-in-chief of that journal, that I met Shirin Heydari, our next speaker. Shirin is a senior researcher at the Gender Center of Geneva Graduate Institute. Her focus is on gender experience of forced displacement and repercussion on sexual reproductive health. She is also the founder and executive director of the GENDRO, a Geneva-based association dedicated to advancing gender-sensitive research. Shirin will present to us research around transactional sex among migrants and refugees in Europe and Middle East. Shirin, please.
Well, great. Thank you so much for the opportunity for us to present the finding of our multi-country research on transactional sex and forced displacement. And see this presentation as a teaser. We have a massive research that cannot be summarized in 10 minutes, but we will have a launch of our multi-country report on the 20th of June. So if you want to hear more, you're welcome to join there. kind of start with that, I'm sure that most of you have come across media reports, news about transactional sex happening among refugees and forcibly displaced population in different settings. What you might not have noticed that the transactional sex is a term that is often confused and conflated and is used to refer to a variety of practices that vary both in meaning and in kind of a motivation. Sometimes it's referred to as sex work and survival sex. Other times it's kind of referred to as sexual exploitation and abuse, in particular when it's in the context of UN peacekeeping forces, and even at times it's conflated with trafficking. And this confusion and conflation of terms and also a lack of evidence has created a policy conundrum so that the policymakers and program implementers do not actually know how to deal with this rather common practice. And the literature on transactional sex in forced displacement has also been quite polarized. On one hand, there is the narratives around people as helpless victims, and the other one is those that they are actually seen as fully in control. What this literature fails to examine is that agency and vulnerability can actually coexist in the context of forced displacement. And the literature has actually failed to look at how vulnerability is constructed, how structural factors create zones of precarity and asylum processes and humanitarian system, what kind of a role they have to play in terms of producing and reproducing and reinforcing gendered vulnerabilities that facilitate transactional sexual practices. And that's why we conducted this research, to really generate a more nuanced evidence of the complexities that surrounds the transactional sex and understanding the gendered patterns and drivers of transactional sex and the health implications, specifically focusing on sexual and reproductive health and mental health implications. This was multi-country studies. We conducted these studies in urban settings across 5 countries, in Jordan, Lebanon, Turkey, Greece, and Switzerland. And this is mainly qualitative studies across different qualitative methodologies. What is important for me to note here is that partly the eligibility criteria was adult refugees, regardless of gender identity and sexual orientation, above the age of 18, and they had no other inclusion criteria specifically related to potential experiences of transactional sex, knowing that this, first of all, is a term that is not used or very well understood, and second of all, this is a very stigmatized practice, so that it would be very difficult. So we kind of really kept the research open. And we applied the working definition of transactional sex that simply includes any engagement in sexual activities or intimate relationships with the intentions of having a material or non-material benefit. So we did not use the term transactional sex just because to be able to capture the diversity of experiences through our research. Very quickly, we engaged more than 400 research participants across the 4 countries over several years. And for the purpose of this presentation, I will focus mainly on the findings from the in-depth interviews. Now, this is still a qualitative research. So at the same time, we also felt that it's important for us to highlight how common this practice is. So looking at all the transcripts and all the in-depth interviews, you could see that 77% of those that participated in in-depth interviews reported having experienced or observed transactional sex. And a note about the methodology is, because of the stigmatizing nature of transactional sex, we applied indirect questioning to allow participants to also share personal experiences as someone else's, as a way to reduce desirability bias and reducing stigma and risk associated with kind of disclosure of such practices. Nevertheless, 12% of our participants reported actually having personal experiences, and you can see that variation across different countries. Transactional sex took very different kind of forms in terms of sex work. Some engage in sex work, which refers to more the explicit negotiation of sexual activities in exchange of money. Then there were transactional sexual encounters, which were more opportunistic and ad hoc, and it was more implicit negotiations or implicit understanding of exchange, often including also non-monetary benefits, housing, accommodation, return, perhaps a favor, crossing borders, transactional relationships in terms of people engaging in a more long-term intimate relationship with the purpose of gaining some kind of a benefit, and temporary and convenient marriages, which were more common in certain regions and certain settings. It's also important to highlight that despite the level of agency that is also present, transactional sex actually very frequently occurred in the context of threats, extortion, and intimidation, often constituting the sexual exploitation and abuse, and we also observed quite a lot of amount of violence. Looking at the practice across different groups, we could see that most cis hetero men and women had experienced or witnessed or observed transactional sex, but nearly all queer refugees had experienced or observed transactional sex, which highlights to the multiple and intersecting vulnerability and marginalization that they face that might actually lead to a higher experience. Obviously, there are multiplicity of gendered patterns. We noted that women without documents, single mothers, those without families were more vulnerable to transactional sex, often engaging with partners or men from their own community, either during the migration journey or in camps, to ensure that they have some protection against sexual violence and harassment from others. Young men, in particular in Greece, who did not identify as gay, reported having sex or living with older men, and in some cases even older women, in exchange of housing, food, money, and other items. And we also, again, saw kind of a high number of reports among queer refugees, particularly trans refugees, who also engaged in order to be able to secure money for hormonal therapy or transition surgeries, which, again, results in very limited access to healthcare services. We have a huge amount of data, so I will not go to that. This is literally my last slide. Looking at the drivers of transactional sex, obviously a lot of that are structural drivers. Slow processing time, the protracted legal uncertainty, and the legal liminality that refugees often experience for extended periods of time results in a ripple effect on a variety of different rights and issues, including limited rights and benefits. Most of the people are not allowed to work, to engage in formal work and labor, which results that they either engage in informal settings where there is huge amount of exploitation and abuse, as well as again, they will have very limited livelihood options, which results in financial insecurity, another very important driver of transactional sex. Housing precarity continuously comes up as an issue that is particularly pressing, with people moving places, not having a house, not being prioritized in terms of access to accommodation that are offered by facilities, homelessness, and that, again, another driver where people feel forced to or choose to engage in some kind of a transactional relations of any kind or any form for accommodation, either short-term or long-term. And it also kind of brings up other elements of violence and exploitation when they are forced to actually tolerate violence in that context as well, with no other options or resorting to other areas. And limited access to health services that remains hugely important, both as a driver as well as an implication, knowing that transactional sex engagement in itself increases risk of gender-based violence, sexual and reproductive health concerns, HIV and STIs, and a number of other health concerns, mental health issues, and that there is generally very limited access to services across countries, more or less. This was a huge undertaking, again, thanks to all the participants who shared their stories and our amazing research consortium and all the majority of partners. And finally, please save the date and join us at the Graduate Institute if you want to hear more, and looking forward a discussion.
Thank you. Where are you going? Where are you going? Stay with us. Stay with us. Stay with us. And I invite also the other speakers for a short session on the Q&As. Dr. Said and Diana, thanks. So Anja will be my valet. So, do we have any questions from the audience? Yes, I see someone there.
Can you
Please.
turn on this mic, or do I have to take a different mic? Is that on? Okay, thanks.
Thank you very much for the lovely presentations. I would like to have I have a question for the Moldova panelists. You did a project on non-communicable disease, but knowing that Ukraine is among the highest TB affected areas in Eastern Europe, did you also manage to see other comorbidities like HIV, tuberculosis, or drug-resistant tuberculosis among the people that you have access to? Thank you.
Thank you. Thank you for your question. Healthy Life project was focuses only on non-communicable diseases, but in Moldova we have another organization project who manage other diseases. Thank you. Not Healthy Life project.
Do we have any questions from the room?
Yes, here's one.
Thank you. I would have a question about the situations of Afghan refugees in Pakistan. You mentioned the marginalization of the Afghan community in Pakistan, and since the talk after, you spent so much time talking about community involvement. What could you say, what do you see in the relations between the Afghan refugees and the host communities there, and could that be an angle to put more equity into the health situation between those two parts of the population? Thank you very much.
Thank you. Yeah, I mean, a very pertinent question in relation to the current situation of relationship between the local communities and the Afghan settlers over there. I must say that, as I mentioned earlier, that this is a third generation of Afghan refugees who has brought up over there. So their roots are quite deep. They have now assimilated quite very well in the local community. There is no discrimination or bias apparently or significantly or obviously from that point of view. So they are very well integrated into the society. They are availing the services, I mean, all that but a point is this, that the disparities which I'm referring to, they still exist despite the fact that they are living there, but somehow they have not been accepted at the official level, I must say. That is the root cause of these disparities arising out of all this situation. For example, I mean, let me give you a practical example and concrete one as well. If some Afghan young girl or boy goes to registration authorities in Pakistan and asks for registration, which is known as identity card, some photo ID, to apply for that, they will, he or she has to pass through a plethora of difficult situations and paperwork just to get it established that that person is born in Pakistan and that has links to Pakistan, despite the fact that this is the third generation which is in Pakistan. So yeah, the face of community is quite different, while the face from the official side is quite different. So short and long answer to your question is that there is, I don't see any from my own personal experience as well as observation that there is not any much difficulty I can see as far as Afghan refugees concerned in Pakistan are living in the community from community point of view. But from other point of view, from official point of view, from other registration point of view, things are quite different. Thank you very much.
There's another one here and there.
Thank you very much, Shirin, on the wonderful study. And a very simple question. It seems that the prevalence of exposure to transactional sex increase the closer to Switzerland you get. So does it mean it's a kind of cumulated experience along the way, or there is something special about Switzerland?
Great, thank you so much. That's a very, very good question. First of all, just to know that we have to be really cautious about the prevalence because this was a qualitative study. Nevertheless, I think even for a qualitative study, it was very sane. So the country distribution is not where transactional sex occurred, is where the participants were interviewed at the time. And our speculation is, which kind of really confirmed by our data, is that by the time they arrived to Switzerland, they have passed through so many different countries and so many different obstacles that the most of their transactional sexual experiences are actually on the route to Switzerland. And maybe that's why we also see a higher rate in Switzerland. But yeah, that's a very good observation.
There's one more.
Yeah, just a follow-up question. My name is Nadi Emmanuel. So I'm just wondering, among your participants, for those that are engaged in transactional sex, did you identify any of the participants who opened up to you as to the choice of engaging in transactional sex, either as a career, that's a choice, not being compelled by situation? And in your identification of interventions, have you, or in the course of your research, have you been able to identify those who are not compatible with your interventions? For instance, those that do it by choice. And if so, how are you able to manage such people? Thank you.
Thank you so much for that question. I think in the context of forced displacement, and in particular the precarious conditions that people live, choice is a very complex term. Of course, there were people that stated that they engaged in transactional sex as a choice because there were no other options, or that they thought actually the other options were as exploitative or as difficult or challenging. So for that, they thought that, for example, transactional sex provided better income compared to a similar exploitative informal job that they would have. So there is an element of choice and agency in many of the kind of a narratives. At the same time, again, it's really important to highlight, what choices you have in which context. And in a context where your choices are extremely limited, your rights are extremely violated, and you have no means of protection neither from the authorities and others, then the issue of choice becomes, there is a different angle to it. And I think that's what we want to also highlight, that agency and vulnerability can actually coexist in these really precarious conditions.
I think we have time for another one, right?
Yeah, last one.
Hi, a very nice presentation. Sorry if I missed this, but did you have any data on how many percentage of women have to engage in transactional sex? Do we have this data?
Again, we did try to make some kind of a quantitative analysis of our qualitative data with all the kind of caveats that it comes with it. It was important for us to also highlight how common this practice is. So yes, we had, according to our data among our in-depth interviewees, approximately 70% reported having either engaged in or witnessed or heard of. And again, with our methodology, we also assume that this personal experience is probably underreported, having engaged in transactional sex of any kind of form. Some of them could be actually temporary marriages that is sometimes more common in Muslim majority country settings, or convenient relationships. So it could be construed in different ways, but often with the intention of some kind of a benefit.
Thank you.
I would like to thank the participants in the room for the very interesting questions, and to thank our three panelists for their presentation, for the evidence you bring, for your experience in the field, first-hand experience. And I think I give back to our Master of Ceremony for the continuation, or unless...
Of course. Now, Rodolfo, before
Please.
we pass on to the next moderator, I wanted to ask you if you had any key takeaways from the session.
I put my glasses because I took note, but I'm getting old, so I need to... So, first of all, we definitely have an alteration of what are the social determinants of health. People live in a way that probably they were not used to, with exception probably for Afghanistan, where you said a third generation of people living there. Still, there is an alteration of what one would wish to be the social determinants of health, that these bring to change in behavior. And we see with the transactional sex presentation from Shirin, and change in health outcomes. Health outcomes are different. However, as Diana presented, the evidence is there that things can be done, okay? And the health sector cannot solve it all. So as we heard all along the day, it's well beyond the health sector. There's a need of community engagement, so we're waiting for that.
All right. Thank you so much, Rodolfo. A round of applause, please. Moving on to the second part of the session, it is my pleasure to introduce you to a medical doctor specialized in general pediatrics. She has been working in children's hospitals and a private practice as a pediatrician, spent some time in the field in several projects with the Médecins Sans Frontières, MSF, and is now working at the Swiss Tropical and Public Health Institute in Basel, Switzerland. Please give a warm round of applause to Dr. Anja Juncker.
Thank you very much. Wow, this slide is really interesting. I see what you mean. No, thanks a lot. I don't want to spend a lot of time for another nice words. We know about the topics and we heard already great initiatives to support people on the move. So we come to the second part where our presenters will show further possibilities to either strengthen migrants, people on the move, in helping themselves or really closing gaps in the system to access healthcare. And I would like to introduce our first speaker, Dr. Rafael Ruiz de Castaneda. He's an animal disease ecologist leading the One Health unit at the Institute of Global Health at the Faculty of Medicine at the University of Geneva. I'm really looking very much forward to this talk. He will speak about a first certificate of open studies on advanced community health designed for refugees and people on the move. So we will hear from the context of Kenya, Niger, and Jordan, and the stage is yours, and I welcome you to hold your presentations. Thanks. There's another mic there.
Thank you very much. We have very little time, I think, and I just want to make a quick statement. I'm half Swiss, half Spanish, so I tend to have this personal, internal conflict of interest with time, so I just hope my Swiss part will dominate this time. So anyway, let's move on to the presentation. As said, this is a very new, ongoing project, so the data and the results we are going to present today are very, very preliminary, a lot of material to digest, to interpret over the coming months to keep scaling up this project. But it's been a very, very exciting year, 2 years basically, building the project and running it now. It's been implemented in 3 countries. And it's the very first certificate of open study of the University of Geneva, targeting specifically community health workers and individuals interested in an activity around community health in humanitarian settings. First of all, let me clarify InZone. So InZone is a program, a platform, a group at the University of Geneva that has been working on offering higher education and university-level education to refugees in different parts of the world for more than a decade now, offering a diversity of formats, program, and type of educational programs, and covering also different type of domains. But what have we seen very interestingly, and this is where I had the opportunity to come in as part of InZone, is the health and the public health and the medical field gaining a lot of importance and becoming increasingly part of the offering, the educational offering of InZone programs. And this is where we have really started building this certificate of open study, which is the first one for InZone, the first one for our university, and specifically focused on community health. We are working here with 3 sites, as you can see on this diagram, on this map. So, and basically the cohort, we have 3 cohorts running in parallel. I'll give you details in a second. So 1 group of students following the program in Azraq refugee camp in Jordan, and then 2 in sub-Saharan Africa, 1 in Niger, and then a bigger group in Kakuma refugee camp in northern Kenya. So the objective, or the general objective here, is really supporting and partly trying to tackle also the medical desert and the fact that, and we have in the room our colleague, Dr. Sila Montes, who's a health manager of Kakuma, of IRC in Kakuma refugee camp, and she was mentioning, and we've discussed a lot this, we have 6 medical doctors currently covering in Kakuma refugee camp a population of more than 250,000 people, so more than the population of Geneva, with only 6 medical doctors. And this is where the community plays a critical role, and empowering, engaging, collaborating with the communities and community health workers is absolutely crucial. So we've identified a number of highly motivated individuals who have a real interest in initiating and getting trained in community health and playing a role at the community level. So this is where our program comes in. The target population, I've mentioned this already, so we are targeting specifically refugees, but more broadly, we've had also an interest in coming from the host community, and we are gradually trying to open up more and more the program, not only limiting it to refugees, but also to the host community. So 5% of the students following the program in this very first round are also part of the Kenyan Turkana community. Here are some quick numbers. So we had many applications coming in from Kakuma. We had more than 100 applicants coming from Kakuma, and then from other sites, so Difa and Niamey in Niger, and then Azraq, 40 and 40, as you can see there. And we went through all the CVs, all the motivation letters, and English test, and we ended up with a group of 79 participants that follow the program starting in September 2023. And we're very much trying to align with the academic activity of the University of Geneva, and I'll give you more details in a second. But here, just a snapshot of the diversity of students that follow this program, and we really tried also to bring them together as a whole. So the 3 cohorts were following the program in parallel, all together, trying to have a really international, collaborative spirit between the three sites where INZON is active. Here are some additional numbers. So for Kakuma specifically, that's the diagram you see on the left. So Sudanese and South Sudanese communities are really the biggest part of the group, as you can see, with 31 and 28% of the group, and then quite an heterogeneous group of other nationalities being represented in the refugee community. I think in terms of female representation, we are getting better and better with 38% of female. We can improve this, and we are working hard to get these numbers up, but it's already a significant representation, I think, compared to what we've seen in other programs. And just to give you a very, very quick overview, it's a very comprehensive program. It really covers a full academic year, so started in September, as I said, fully aligned with the academic activity of the University of Geneva, finishing in a couple of weeks, so we are really running the final modules these days, with the final exam in a couple of weeks. And it covers really the pillars, the basics, the fundamental elements, I think, of community health programs, because there are already many community health programs out there. But on top of that, we've also tried to include additional elements that tend to be neglected in many community health programs that we have evaluated and analyzed, including, for example, so mental health and disabilities, or neglected tropical diseases, NCDs that also tend to be shadowed in many cases by infectious diseases. We had also, actually it's this week, still ongoing, a module with a workshop on digitalization and what's the role of technologies and e-health in the context of community health and the work of community health workers. Very important point at the very first line. So it's a program that is a certified program, so students at the end of the program will get the certificate of open studies, but on top, also 12 ECTS credits officially recognized by the University of Geneva. And as you know, ECTS credits are the academic coin that we use across universities in Europe, but also more and more across the world. And I think this is particularly important because we've seen many academic programs at different levels being offered in humanitarian settings, but not necessarily all of them are certified or credit-bearing, which makes a whole difference, I think, for the students. We took a very co-design, co-construction, multidisciplinary, cross-sectorial approach with more than 40 experts involved in the process through the building and the delivery process. And you see here some partners, some collaborators involved in this process. Different teaching and pedagogical approaches, and this is also my colleague Florent Dupertu, who's been supporting us very closely in the whole thinking around innovative pedagogical approaches to this project. And just to give you a couple of examples, so we have more classical, I think, video lectures, online lectures. So there is obviously a virtual, online, remote dimension in the whole learning process. A lot of interaction, so we have through the year regular interaction and opportunities to interact with the students all together, so 3 sites simultaneously, with many questions, many challenging and exciting questions coming and challenging our experts. At the same time, as you know, community health is, and particularly the work that community health workers deliver in the field, is very much field-oriented, very practical, and that's where they can only learn by doing, right? So that's why we had established partnerships with key players working at the front line, and this includes IRC, the International Rescue Committee in Kakuma, Save the Children, among others, and we offered and we gave the opportunity to our students to follow practical workshop over several days through the year in very specific topics where they actually left the online experience and went into the field to see how things actually are materialized in the field. We took this very seriously, also for the students. They had some real academic pressure, if I can put it that way, where there was a final exam at the end of the first semester, and in 2 weeks' time we have another final exam for the second semester. Again, this is credit-bearing, officially a certificate by University of Geneva, so we try to respect the official rules from the University of Geneva as much as possible. In terms of dropout rate, which is very important in this very unstable and complex situation, I think we're doing pretty well, but this will be obviously improved over time. So we have a dropout rate of 20% for Niger and 30% for Kakuma and Azraq, and we have a very quite detailed information on what were the reasons, what were the reasons that justified the individual dropout rates that we've seen. In general, the attendance is up to 75%. So they follow the program, they follow the activities, they participate to the different speak-up sessions quite actively. This is the initial round of evaluation that we did internally, again, following the recommendation of the University of Geneva, but we are in the process of setting up a much in-depth evaluation and impact evaluation of the program, but this already gives us some positive feedback, often too positive that it has to be complemented with focus discussion and in the field, so combining qualitative and quantitative analysis, but I think that the return that we have from the student is rather positive. And this is my very final slide. As I said, it's an ongoing program, it's an ongoing project, very first round, so much to digest and to learn from the different sites where we have also interesting comparisons and discussions going on. We are considering different possibilities like packaging the program more instead of having a full academic year, packaging it into 1 semester, not 2, that's one possibility, reinforcing the practical dimension of it, among other questions like trying to also have a specific component where community health workers not only deliver practical work in the field, but they also engage into research activities. That could be also something that we want to explore in the future. So I'll stop here, and I thank you very much all for your attention, and also all the partners and collaborators that made this project possible.
Thank you very much, Raphael. That was really indeed very, very interesting. And thanks for keeping your Swiss side alive on the timekeeping. So yes, I want to invite now Monica Trentin to the stage. She's holding a Bachelor's in International Studies and a Master in Governance of Emergency, finalizing her PhD in Global Health, Humanitarian Aid and Disaster Medicine. In her research, she generally focuses on exploring vulnerability of migrant women during disaster, which will also be the talk of today. She will speak about being a migrant woman during disasters, a mixed method study exploring multidimensional inequalities during COVID-19 pandemic in northern Italy. The floor is yours. Thanks a lot.
Good evening, everybody. I'm very happy to be here and to have the opportunity to present this study. I can see okay, now it's working. So yes, I'm very happy to be here to present you this study that has been conducted within a larger project, being a migrant woman during disasters, a project that brings together disaster field and migration field, and that starts from the assumption that disasters affect people unequally. And among the most vulnerable groups, there are certainly migrants, but also women. And while research tends to address peculiarities of either migrant or women in isolation, we try to fill this gap with this study, which aims to explore the impact of the COVID-19 pandemic on migrant women in Milan, with a specific focus on access to care and socio-sanitary needs. It's a mixed method study, and today I will be presenting one of the studies conducted within this project. So, in this case, we explored the impact of the pandemic by leveraging on a pool of key informants that served this community during the pandemic in order to understand their perceptions on what happened and also understand how challenges experienced by professionals and their organizations resulted in negative impacts for migrant women. We also conducted a qualitative study with migrant women. There is a poster on that, and if you're interested, I will be in the poster area after this session. So we conducted with them qualitative, semi-structured interviews building on this framework that is the result of a systematic review of the literature that I conducted within my PhD. There are details at the end of the presentation. So this review had the objective to explore, to conceptualize the meaning of vulnerability of migrant women during disasters. And we identified several vulnerability factors and showed how these translate in negative impacts for migrant women during disasters. So our interview guide builds on this framework. So you can see that we explored several different topics. We managed to conduct 27 interviews with 28 key informants working in 7 organizations in Milan. So we managed to have a quite broad understanding of what happened in the city during the pandemic. There are no similar studies in Italy, so we are quite happy about it. They worked either in public hospitals or third sector organizations such as emergency NGO that maybe you are quite familiar with. So considering the topic of this conference, I will briefly tell you about results more related to the health sphere, while in a few months I hope that you can be able to check out the publication and learn about all the other results. So when it comes to mental health, migrant key informants reported that migrant women were much distressed, either because they lost their job or because they feared of losing it after contracting COVID. And one nurse actually told me the challenges she experienced when she had to tell migrant women that they were positive to COVID, because she was aware of the consequences that this could have on their job. This frequently led to frustration because migrant women were then unable to send remittances at their families in the home countries, which is often the reason why they migrate at first. And of course, the regularization process and then empowerment path was undermined because of the closures, bringing much fear and uncertainty about the future. When it comes to physical health conditions, of course, migrant women tend to live in overcrowded apartments, so social distancing was often impossible. And interestingly, cultural patterns were identified when it comes to self-protection mechanism towards COVID. So, for example, it was disclosed that Roma communities was much skeptical against COVID, and many migrant women were also bothered not only by wearing masks themselves, but also by professionals wearing masks when interfacing with them, interacting with them. When it comes to transgender migrant women positive to HIV, much often they were unable to follow the antiretroviral therapy during the pandemic. When it comes to access to care, the main barrier was experienced when it comes to the vaccination campaign. In Italy, it was stated that everyone should have access to the vaccination regardless of their legal status, yet the booking platform where people had to register for vaccination prevented migrants from doing so because they had to enter specific information that they did not possess. So vaccination for migrants was made possible only after a few months, thanks to the pressure done by third sector organizations. Overall, it was disclosed that migrant women accessed care less than prior to the pandemic, especially when it comes to access to sexual violence relief centers, and to consultation for termination of pregnancy or family planning. So we can assume that this was because of cohabitation with partners during the pandemic. And in general, they tend to not access to care either because they had children or much often it was reported that caregivers were prevented from seeking care because their employers feared they could bring the coronavirus at home. Just to wrap up the results of this study, again, it's a super brief summary because we have just a few minutes, but if you are interested, please contact me. I will be happy to share the publication with you soon. So we understood that the pandemic did not create new vulnerability factors for migrant women, confirming the results of the previous systematic review, but rather exacerbated pre-existing vulnerability factors, especially when it comes to job, because we know that migrant women, unfortunately, are still channeled into a very limited array of jobs that were the most disadvantaged during the pandemic. Our study showed that, in particular, caregivers and sex workers were among the subgroups most affected by the pandemic. And interestingly, despite involving almost 30 key informants working in different organizations, third sector organizations and public hospitals, they all shared the same perceptions and identified similar barriers affecting migrant women, regardless of their legal status of being migrant or asylum seeker or length of stay. So we tend to think that when you stay in a country for 10 or 15 years, you are more resilient or you have less issues, but we showed that this is not always true. And on a positive note, third sector organizations, despite facing several challenges themselves during the pandemic, achieved to implement adaptive mechanisms and to show resilience. So this is a very good result that we have from what happened in Milan. Interestingly, and I will conclude my presentation, the results of this study differ a lot from what migrant women themselves told us. So if key informants tend to depict them as particularly vulnerable, marginalized and fragile, we learned from migrant women that actually they feel that the pandemic did not affect them so much, neither in comparison to migrant men or non-migrant women. So in the papers, we are also trying to give some explanation to this difference that is quite interesting to us. So if you are interested in learning more about these projects, about the review that I presented, there are my contacts. This is the QR code. Again, if you are interested in the other study, 5:30 in the poster area. Thank you so much for your attention, and I remain available.
Thank you very much, Monica. This is really interesting, so we definitely have to keep in touch here. And as a third speaker, so the last, but definitely not the least speaker of our session today is Stefania Paduano. She's a researcher in hygiene and preventive medicine at the University of Modena and Reggio Emilia in Italy. No, Emilia, Italy, sorry. And she holds a PhD in clinical and experimental medicine. Her current research focuses really on collaborating for standardization of new instruments, really at supporting pregnant women mainly. And she will speak about today evaluating the health status and prevalence of HPV, HIV, active TB, latent TB, and syphilis among asylum seekers hosted in Modena province in Italy. Thank you very much.
So, good evening. Thank you for the presentation, and thank you, the organizer, for the opportunity to share our work during this conference. As we know, the health of migrant and asylum seeker is a challenging issue for healthcare system and healthcare workers. Also due to difficult migratory path of this particular vulnerable population. In Italy, since 2016, public health departments have been implementing medical visits and screening for infection diseases among asylum seekers. A brief focus on Project iCare. Project iCare is a European project promoted by Emilia-Romagna region in collaboration with the other 3 Italian regions, Lazio, Sicily, and Tuscany, aimed to improve the access to territorial health service for migrants and asylum seekers. Thanks to this project, healthcare workers and cultural mediators were trained on the healthcare system for assistance and for reception of asylum seekers. In particular, in Modena province, a specific protocol for asylum seeker has been implementing with medical assessment and screening for infection diseases. Also, this protocol includes a doc pathway active for asylum seekers who need secondary level care. For this protocol, we created a multidisciplinary team, including different specialists in different medical areas, such as infection disease, dermatology, psychology, radiology, gynecologists, pneumologists, and preventive medicine. To guarantee primary level care during the first visit, we need 2 healthcare professionals, 1 medical doctor and 1 healthcare assistant, plus cultural mediators. For secondary level care, we need 1 reference specialist for each medical area. Our study aimed to assess the health status and the prevalence of different infection diseases, such as hepatitis B, hepatitis C, HIV, syphilis, active and latent tuberculosis, among asylum seekers hosted in Modena during period 2021 and 2022. We included all asylum seekers referred to the Modena Center in this period. And on the right side, you can see the checklist used to collect socio-demographical and clinical data during the first visit, aided by cultural mediators. After the first visit, we also recorded results from blood tests for infection diseases. Brief focus on tuberculosis. We adopted a 3-level active surveillance system, including tuberculin skin test. If positive, we performed the quantiferon test. If quantiferon test resulted positive, the asylum seeker underwent X-ray and pneumology visit. We included 423 asylum seekers, 13 female, 87 male. Average age was 25 years, 3 to 49. Regarding place of origin, most of them were from sub-Saharan Africa, followed by Bangladesh and India. And the most frequent signs and symptoms were related to cutaneous diseases, followed by gastrointestinal, cardiovascular, and respiratory diseases. For 25 subjects, a special visit was requested. Regarding screening for infection diseases, 306 migrants underwent screening, and we recorded positivity for hepatitis B in just over 4% of our population, and for 1% positive for hepatitis C, HIV, and syphilis. Regarding tuberculosis, only one subject had active tuberculosis, and 78 subjects were preventively treated for latent tuberculosis. Moving on to conclusion, I would like to synthesize my conclusion with 3 words. 1, multidisciplinarity, timing, and training. Why? Surely the multidisciplinary approach is the innovative aspect of our protocol. And timing. Why? Because medical checkup performed shortly after asylum seeker arrival in our province ensure the management not only for acute condition, but also for chronic pathologies, also therapy treatment who need. And training, why? Thanks to Project iCare, healthcare workers and cultural mediators were training in this specific area to guarantee, to allow the overcoming of language and cultural barriers and to better approach the asylum seeker to healthcare system. Finally, the collection of socio-demographic and clinical data will help to guide health policy and public health programs to protect these vulnerable subjects. I would like to thank working group, in particular Dr. Borsari and Dr. Kapian, our front line of local health authority on Modena, and Professor Filippini and Dr. Latore of University of Modena and Reggio Emilia. Thank you all for the attention.
Thank you very much. May I invite Raphael and Monica to come back on the stage, please? Thank you very much. That was really very interesting. You need to know what you look for, and then you find so many times in medical care. So are there any questions from the audience? I don't see anything. Yes, there is a question. Okay, thanks, Rodolfo.
Thank you, everyone, for your insightful presentations. It was indeed interesting to see your research and your projects. I'm Alessandra Costa. I'm from Italy. I'm studying public health in Barcelona right now. And I have a question for Monica regarding your study. I was wondering if in the planification of your study, you were wondering or you considered doing a comparison in your qualitative studies between like migrant women and local women, and especially also considering the perspective of key informants regarding the experiences they observed in both cases, and if not, why, and if yes, why finally you didn't consider it in your study? Thank you.
Thank you for your question. So, first of all, we have to keep in mind that this project is a funded project. It lasts 1 year. So we have to, take this into consideration. But still, yes, we are trying to do some kind of comparison. More in the quantitative part of the project, so we are exploring the impact of the pandemic using data sets from an emergency department in Milan and the mobile clinic of emergency NGO. So in these two cases, we are comparing migrant women with both non-migrant women and migrant men from a quantitative perspective. During the qualitative phase, we also asked both professionals and migrant women about this about how they perceive this difference. And as I was mentioning earlier, migrant women told me that they do not perceive themselves as more vulnerable than non-migrant women, at least regarding the impact of the COVID-19 pandemic. So yeah, I hope I have answered.
Thank you. There was a second hand up, right?
Okay, thank you.
We have some.
Thank you for your presentation. I'm Jacques Madère. I have a question for Raphael. It's about the training of community health workers in the camps. I find this a very interesting project. Are the community health workers trained both in the camps and in the surrounding population, a recognized cadre in the 3 countries? And if yes, have they a good prospect to have a job in the future? Thank you.
Yeah, thank you very much for the very relevant question, and which is a critical question, by the way. I mean, it's what comes after, okay? And so there are different components, I think, in my answer. So first of all, one of the things that we very much trying to do from the very beginning is engaging and establishing partnership with local NGOs, local players who are really already collaborating with the community health workers that follow our program. And this is the case for IRC, for example, in Kakuma refugee camps, where some of our students already collaborate with them. And partly our program is potentially going to support them through that journey, through that career, potentially opening opportunity for internal promotion, or at least development of their career within that organization or other organizations. So that's one important point. Then more broadly, how our program is going to fit into a broader academic landscape, regionally and nationally in the countries where we work. This is something that we are definitely exploring. We don't have yet the final solution for this. It's ongoing negotiations. In some cases, it requires one-to-one bilateral relations with specific universities when it comes to students, refugee students in Kenya with Kenyan universities or back in their home countries. But one of the, I think, elements that makes it potentially feasible is the fact that we're using ECTS academic credits, that also this is a very much European concept. There are many initiatives, and actually there is a big European project that has been running for more than a decade now, called the Tuning Project, where they've been trying to use the ECTS, again, an academic coin, all across sub-Saharan Africa, and more universities are engaging into that process. So I think open opportunities, but still a complicated process.
Thank you. Are there any further questions? While while you still think, I would actually have a question to you, Stefania. It's a pretty simple protocol that you sort of applied. Why would you think, or ask positively, do you think there is any possibility to transfer this to any other setting where you receive asylum seekers or migrants or people on the move? Like, or what would you consider a barrier? Because it seems so obvious and self-evident to just apply it, because then you find problems and you can treat them.
Yes, I think there is one barrier, fundamental barrier in terms of resources, financial resources, but mainly the healthcare workers' resources, because to date, for year only in Modena province, we received 1,300 asylum seekers. So we, in this study, we had only 423 in 2 years. So we have a problem because there is asylum seeker without access to territorial health service. Only because if this protocol was not in place, the only asylum seeker would only access in case of emergency. So doesn't any check medical assessment for them.
So we would miss all these infections. Yes, thanks a lot. So any other question? If not, we don't want to prolong this unnecessarily because I know people also have to run and it's a long day anyway. So I'd like to thank you, the 3 panelists, and I hand over to our master of the afternoon.